Ooh, I'm seeing a lot of gardening. What are people gardening? What gets planted or gardened at this time of year? Hello, hello. Welcome to the Zero Suicide Learning Collaborative. We're going to give it just another couple minutes before we get started. But in the meantime, if you could please put your name and organization into the chat while we get ready, that'd be awesome. And our community check-in this morning is what you're most looking forward to this weekend. I'm loving all these fun plans. I need to stop asking about food at the start of these calls. We are a little too far from lunchtime, and now all these fresh veggies sound amazing. All right, I will keep bugging you to put your name and organization into the chat as we get rolling here, but I'm going to turn it over to our guest today. Robin Shaw from UC Health is going to be talking about their zero suicide implementation in their system. Really looking forward to your presentation, Robin, and thank you so much for lending your time and expertise in zero suicide with us.
Oh, thank you. I'm going to apologize ahead of time. I have a horrid cold and I know I sound pretty bad. So I'm sorry that you have to listen to this voice for the next portion of this collaborative. But very excited to be here today, honored to be asked to share. And just want to start off by saying it's not just me for UC Health. We have a lot of individuals that help run this program for UC Health, and I'll talk about that during my presentation as well. I'm going to go ahead and share my screen. Connellan, please let me know if you're not able to see it since how I backed out and came back in. Can you see that okay?
Yes, looks great.
Awesome. I'm going to go ahead and start from the current slide, if it's going to work for me. So it's definitely been a journey getting zero suicide implemented into UC Health. We have several different regions in which we are trying to implement zero suicide and 12 different hospitals. And I'll show you the breakdown of that as we go. But again, it is not just me, it is a system-wide effort. And there's a lot of people putting a lot of hard work into this journey. When I took the Zero Suicide Academy, which if you have not taken it, I highly, highly recommend taking it. It was amazing and really helped put a lot of things into perspective for me. But some things that I really took to heart and words of wisdom that stick with me on a daily basis is implementing zero suicide is not a marathon. Is a marathon, not a sprint. It takes time to be able to do this. You're not going to be able to do it in a short amount of time and a very fast pace. It's just not going to happen. So think of yourself as training for that marathon and knowing it's going to take a while to get there. Also, some other words of wisdom that one of the facilitators had said on that academy is it's like a faucet with a trickle of water. So you don't want to turn the faucet onto a full gush or it's not going to go the way that it needs to go. You may get it done, but just not appropriately. So please take it very slow as you move forward. So I wanted to kind of give a timeline of how long this has taken UC Health, because again, it was not overnight. It's definitely taken us a bit of time to move forward on this. Talks of implementing zero suicide started back in 2015. with Billy Ratliff. At the time, she was the manager of behavioral health down in the Southern region. She is now the director of behavioral health in the Southern region. But she had this passion and wanted to move forward on implementing zero suicide, but some barriers that kind of got in the way. Leadership buy-in. Leadership just really wasn't on board for providing any kind of funds or resources to getting this up and running. And so Billy tried to do these things on her own while having a full-time job as a manager, but also taking on the implementation herself. She worked at that from 2015 until about 2019. And during that time, we, meaning Billy, was able to obtain a grant from the Colorado Springs Health Foundation. And that grant was able to provide the funds needed for a full-time zero suicide coordinator. And so at that time, Andrea Wood, who is now the manager of behavioral health in the Southern region, was brought on as the zero suicide coordinator. And she was absolutely phenomenal in her role as the coordinator. But as we know, as time went on in 2020, COVID hit. So as she's trying to get the team up and moving, trying to have meetings, trying to make policy changes, doing everything that we know zero suicide implementation takes, everything was put on a halt. Anything that was not a mandated or mandatory meeting was shut down. And so Andrea tried the best that she could to get things going behind the scenes, and she did keep working at all of those things. Just nothing was shared up front because we weren't allowed to be having those meetings at that time due to COVID. However, in 2021, UC Health as an entire system adopted the zero suicide principles. And that's not to say that the other regions were already working on zero suicide, because the northern regions had started working on that as well, doing a really great job. So I want to make sure that they get the understanding that they were doing everything they could as well. And so at that time, though, all 12 hospitals across the region started adopting the principles, and we started working as a whole system to get zero suicide up and running. And then in March of 2021, I was hired as the zero suicide coordinator for the Southern region. And at that time, we also received more support from CDPHE. Thank you so much, Connellan, in the efforts to keep it going. And UC Health in the Southern region decided to take on the zero suicide coordinator as a full-time position. So that's really been fantastic for us. But being in that position, I feel like it's my responsibility as well to help all of our regions, not just the Southern region. So I really try the best that I can to reach out to everybody in our system that is implementing zero suicide. So again, I mentioned that UC Health has 12 hospitals that have adopted the zero suicide principles. And so we are really up and down the corridor of Colorado. In our northern region, we have Greeley Hospital, Medical Center of the Rockies, Poudre Valley Hospital, and Yampa Valley Medical Center, and they are amazing up there. In our metro region, we have Broomfield Hospital, Highlands Ranch Hospital, Longs Peak Hospital, and then the University of Colorado Hospital, and that's at our Anschutz location, and they are also amazing there. And then for the Southern region, I'm responsible for Grandview Hospital, Memorial Hospital Central, Memorial Hospital North, and Pikes Peak Regional Hospital. So as you can see, we cover a lot of space within the state of Colorado. So going back to the elements of zero suicide, I really just want to kind of focus on where we are in each element and how we've gotten this far for all of the system of UC Health. So as we know, LEAD is a system-wide culture change committed to reducing suicides. So in the Southern region, again, they have funded a full-time zero suicide coordinator, which is myself. But the other hospitals, regional and local hospitals, do all have implementation teams, and all of those teams meet on a monthly basis. Being the zero suicide coordinator for the Southern region, I do attend the meetings that I am invited to or that they have asked for help in. So I try to be in those to help with where we've come from and what's worked best for us and what has not worked. Because doing an implementation team, we know that there's going to be pros and cons and good things and bad things. So if we can help stop the bad things and move forward on the good things, I feel like that's really important, and to not have to reinvent the wheel for the things that are working well, to share those and keep moving forward. And then I run a system-wide implementation meeting monthly as well. During HQIP, if you guys know what HQIP is, the Hospital Incentive Program, we focus mainly on that and meeting our goals for HQIP. But then once HQIP's over, we talk about what are the next goals we want to move forward on, what's most important and most pressing at each region, and how can we help each other move forward on those. So we just had our system-wide implementation meeting yesterday, and we focused a lot on caring contacts and how do we get that process started and moving forward. So it kind of rolls through very smoothly for all of the regions and what's working best for each of the regions. So for the Southern region, our implementation team, currently we have 45 total members. 6 of those members do have lived experience because we know how important that is. And for our team members, those come from the 4 different hospitals that I represent in the Southern region. We also have community members on our team, and then also individuals who have received services here at UC Health. So I will tell you that was kind of a big one to move into. How do we get patients that have received help from UC Health while at the same time being respectful of confidentiality and knowing where our boundaries are, right? How do we do that? And so it took some time for us to figure out who would be the best community members and those who have received help from UC Health to invite to be on our implementation team. But it's been a really good fit, and they share a lot that maybe we can't. I've not been a patient in our behavioral health here at UC Health, so I don't know what that feels like or how to ask for things to be different. So I do feel like that's an important step for us. I will tell you that all of our monthly meetings, we don't always get all 45 members. And in fact, I think since I started March of last year, there hasn't been one team meeting that all 45 members have been able to come to. But we record those meetings and then we can send them out to those who have missed so that they can still provide feedback for those meetings. So some of the ways that I like to include our implementation team members down here in the Southern region, and I know a couple of the other regions have also adopted this method because they liked how it worked, is I give team challenges each month to our team members. So when we started our implementation team, I asked each team member to please think about what element they feel like they could provide the most expertise to, and to let me know which element that was. And then I put them on what we call a smaller team. So for example, our lead team, one of our team challenges has been to talk to as many people within UC Health about zero suicide, and mentioning zero suicide in every meeting that you attend. Talk to coworkers, whether it's at lunch or if you take a walk or you just happen to be walking down the hall, but you see someone you haven't in a while, talk to them about zero suicide. So when I give these team challenges, they're not things that take a lot of time. Obviously, I recognize that we all have big responsibilities within our job duties at UC Health. So they're just little things that can be done within a 5-minute period. And then each month we come back and we talk about, how did that team challenge go for you? Were you able to talk to somebody new about zero suicide and get the word out about us? And we all have lives. We are all human. And sometimes we come back and the team will be like, yeah, so I totally forgot and that never happened. I get it. Or they might come back and be like, yeah, that was amazing. So the individual I talked to knew nothing about zero suicide. They're really excited about it. They'd like to join the team or they'd like more information. So just little things to get out zero suicide within our hospitals. Some of the other things that we have done under our train element for the individuals involved in train, I asked them to go back and talk to their direct teams about QPR training and getting the word out about QPR and having their team leads reach out to me to get QPR set up for them. For identified little things like talking to somebody about the Columbia suicide severity rating scale and just making sure they understand why that's so important. And we use the nail story, which I will share with you guys in a little bit, but showing why it's so important that we're asking all patients that come into the ED, the Columbia screening. Some of the other challenges I've given for engage, caring contacts is huge. And a lot of times we feel like we don't have time to sit down and get those caring contacts out in the mail, especially if you see a lot of people in your hospital. For the Southern region, I have anywhere between 150 and 300 behavioral health evaluations that happen monthly. So how do we get that many caring contacts out? So for that team, I challenged them to come up with new ways to do that. As far as our transition team, being able to come up with more contacts within our counties to refer individuals to. We have changing therapists within El Paso and Teller County weekly and monthly, who's taking new patients, who's not taking patients at all. And so taking maybe 5 minutes a month to look up one new person. And then lastly, for our improved team, being challenged with ways to figure out how to get the most accurate data. For us right now, we have what's called Power BI, and that is our data system in UC Health. And how do we pull the most accurate data? So again, I'm not asking my team members to do things that take a huge amount of time out of their day, especially since they do have other jobs, but 5 or 10 minutes a month and doing things that can help get the word about zero suicide out. So our system-wide implementation team consists of about approximately 40 UC Health staff members, and that covers all regions and all hospitals. And then again, they have their own implementation teams. So they can take the information we discuss in our big team meeting and then put it out to all of their team members. So we feel like working as a system, we're able to streamline zero suicide for all UC Health staff and all UC Health patients, which we feel like is really important. And then that way we're able to leverage our resources and lessons learned as we go through. There's no point in reinventing the wheel. If something is working great for one of the regions, let's take that and move that into the other regions. And then at the same time, we're able to create standardized evidence-based processes through the whole system. And so the next element that we really try to focus on is train. We want to train competent, confident, and caring workforce, just like everybody else who is doing the zero suicide implementation. So for our clinical staff, for gatekeeper training, we do provide question, persuade, refer. We also do safety planning training, lethal means counseling, trauma-informed care. And then we also provide access to AMSR training, which is assessing and managing suicidal risk. and then CAMS training as well. And then all of our nursing staff and direct patient observers go through the Columbia training. And then non-clinical staff is required to go through the QPR training as well. We are working as a system to try to get QPR training mandated for all new hires. As of right now, it has not been mandated, but it is something that we're working very hard to do. And I wanted to provide, I'm not going to read these to you guys, but I'll give you a couple of minutes, just some feedback that we've received back from individuals who have taken the QPR training. And I thought that it was important to show that even a behavioral health clinical therapist felt like the QPR training was very valuable to them, as well as a care contact representative. So I feel like it's important to show that everybody within a system should have the gatekeeper training, even if it's what we do on a daily basis, because I feel like sometimes we forget the small things or forget what we're doing. We get into a rhythm and just get into our job and do it without thinking about it. So to be able to provide that to everybody is super important. So the next element that we really find very important is identify. How are we identifying individuals with suicide risk via comprehensive screening and assessments? So at UC Health and our emergency departments and acute care hospitals, we do the Columbia screening, and that is for all patients 12 and older. If they are under the age of 12 and come in with a red flag and we feel like it needs to be done, we can absolutely do it. We have an annual training through ULearn, which is UC Health's learning module platform that all nursing staff takes. And then UC Health emergency departments screened over 484,000 patients in the last 12 months. So that's really a big deal. I think the research shows that 38% of individuals who attempted suicides saw a healthcare provider within 1 month of their suicide attempt. So maybe they're not coming into our hospitals for suicidal ideation, but if we can ask those questions, that might be a great time for us to be able to provide the help that they need. Our ambulatory clinics use the PHQ-2 and the PHQ-9 process for all patients 12 and older. And again, if there is a red flag for suicidal ideation, we can go ahead and question the patient if they're under the age of 12. And then all hospitals, ED, and clinics within UC Health have access to 24/7 support through our virtual care, which we call VBHC, and it is on-demand comprehensive behavioral health evaluations. And they do suicide risk assessments utilizing the Columbia and the safety protocol. So something I'd like to share with you that we find really important. In the slide earlier, we talked about the nail on the head story. And we were very fortunate enough to have an intern this year who was able to put that into a PowerPoint presentation that hopefully we can get used throughout our system. But here's the video she put together for us. So Connellyn, please let me know if you can't hear the sound that goes with it.
A man was working at a construction site and accidentally stepped on a nail.
I can't hear the sound, I don't think. Unless anybody else can.
Can anybody out there hear the sound or no?
No.
No.
Okay, I'm going to try one more time. If it doesn't work, I will send it to Connellyn by itself so that you guys can watch it at a later date. No sound?
The man answered that yes.
No.
Okay.
Still nothing. We can send it out afterwards, no problem though. Sorry about that, Robin.
Sorry, guys. technology is not my friend, so I apologize for that, but it's a really good reminder, and it is a true story about why we use the Columbia here in the hospitals. So our next element is engage. We want to engage all individuals at risk of suicide using a suicide care management plan. So in the zero suicide framework, engage broadly refers to the following: a pathway to care that instills hope and is recovery focused, right? That's what we want to do for all of our patients. So here at UC Health, we use the Stanley Brown safety plan across all of UC Health. It is embedded into our electronic health records, which we use Epic. We also use lethal means counseling here at UC Health. In the Southern region, we have been fortunate enough to receive funding from several different sources, including CDPH for gun lock boxes. And so we can provide those lock boxes to our patients and their family members to be able to lock up lethal means safely. That component is also embedded in our Epic system, so that as we're doing the evaluations, we can fill in the safety plan and we can check the box that says, yes, we did lethal means counseling, and yes or no to whether we provided a lockbox. We have also taken the steps to provide and maintain the patient's engagement and show our commitment by creating a care unit 4 packet. So in this packet, there is a welcome letter to patients that end up in our care unit 4, which is our psychiatric unit within Memorial Hospital Central. So there is a welcome letter. There is legal information on what an M1 actually legally means, what patient rights mean. There are a lot of worksheets for patients if it's appropriate for them to work on why they're in the hospital. And if not, then we don't provide those to the patient because we don't want the patient to be triggered at a later point. We want to do the best we can by helping the patient in the moment. But there's also resources for the community for once the patient is released, whether they are discharged with a safety plan or if they are placed in a psychiatric facility, what can they do once they're released from the psychiatric facility? And then we also maintain communication with the individual once they leave our hospital. We provide Rocky Mountain Crisis Partners for the patient if they agree to it. And then we also do our caring contacts as well. So this is just kind of a flow sheet of what the emergency department to inpatient kind of looks like. From the patient walking in the door, if they score moderate or high on the Columbia, they are then consult is put in to see the behavioral health evaluator. Depending on what the behavioral health evaluator deems necessary, lethal means counseling might be done at that point, but they go to the recommended disposition. If they are going to be discharged, we do the safety plan with them and refer them to Rocky Mountain Crisis Partners. If they are not going to be discharged with the safety plan, then we move forward with the full evaluation and psych placement. So our next element is to treat. We want to treat suicidal thoughts and behaviors using evidence-based treatments. That's really hard in the emergency department, and that's something we definitely struggle with, because if they are placed on an M1 hold and they do go into a psychiatric facility, we don't have the time frame that is needed to be able to treat them, right? We're kind of in a crisis situation and we do what's best for them in the moment, and then they move on. However, the patients who are admitted to the hospital are seen by what we call our CL team. They're the psychiatric consult liaisons, and they are able to work with those patients while they're inpatient using evidence-based treatments such as CAMS or CBT, depending on what our CL team thinks is best for those patients. Again, our biggest challenge is being able to treat those that are just seen in the emergency room and then moved on to a psych facility. For the transition element, we want to transition all individuals with care through warm handoffs and supportive contacts. So for all patients, we offer them the Rocky Mountain Crisis Partners. Some of the biggest challenges we find with that is if a patient does not agree for Rocky Mountain to follow up with them, then we're kind of stuck at that point with providing them follow up through Rocky Mountain. However, with our caring contacts, a patient does not have to agree for that contact to happen. So for us in the southern region, once a patient has been seen in Care Unit 4 or on one of our inpatient units, if they have to stay with us longer, I pull their information up in our Power BI data system, and I can send them either a card if they don't have an address because they're transient, but they do have a phone number or email, I follow up that way. Unfortunately, a lot of our transient population does not have any demographic information. So at that point, it's really hard for us to do anything. So that's a big challenge for us. I try very hard to be able to send out or make that caring contact within 3 days to a week of the patient being in the hospital. Because it's just me down here in the southern region doing that for anywhere from 150 to 300 patients a month, sometimes that time frame does not get out as soon as I would like it to be, but the follow-ups do happen. I have been fortunate enough to get 3 volunteers that do write out the caring contacts for me, which has been super helpful. So they don't have any of the patient information. So none of our HIPAA violations are being hit. We are still within the safety of HIPAA, but they write out the cards and then I get them back and go through and address them to the appropriate patients. So from April of last year to April of this year, I was able to send out 3,674 caring contacts. And I will say between the caring contacts and training our hospital staff on QPR, those are 2 of my favorite parts of this job. I really enjoy working with our staff, but also reaching out to our patients. So one of the things that we in the southern region have started to take on, and I hope that eventually the northern region is able to, and the metro region as well, is what we call the stopgap project. So we created this to create assistance with mental health recommendations and resources for those that are not yet established within UC Health. So we have nurse lines that individuals may call in on asking to get established with UC Health and asking for help with medical assistance and mental health assistance. So this project is not mandatory. The nurses do not have to utilize this, but it is available to them if they feel like the patient would benefit from it. So it is not for urgent or same day needs. The patients are told that they'll receive contact between a 7 to 10 day turnaround period. And established patients needing resources are to follow up with their PCP. So our hope down here is it's me and Jessica Mars who teaches QPR with us are the only 2 that do this. And as we get the patients in, we really try hard to actually turn around within 24 to 48 hours. And it's to provide resources for those individuals. We don't get a ton of referrals. This week I had 5 referrals total. So that doesn't take up a lot of time, but we're able to reach out and help those who need the additional resources. So my hope is that eventually it will go throughout the entire system of UC Health as just one more way to stop people from falling through our cracks. So the last element of zero suicide is improve. Of course, we want to improve all of our policies and procedures through continuous quality improvement. UC Health as a system has really tried hard to create policies and procedures as a system, not as separate regions. So right now, the policies and procedures that have been created through Zero Suicide are the assessment and care of suicidal patient policy, the 72-hour mental health hold policy, assessment and care of gravely disabled patients, and assessment and care of homicidal patients. So I feel like that's a great start to where we're going. We do have comprehensive suicide screening dashboard available in our Power BI, which is what I talked about earlier. It's our data system. And so when somebody is screened through the Columbia, we can go in and see how many people screened high, how many people screened moderate, and that's how we're able to go back and send out or complete our caring contacts. And then for the southern region, we have a really close relationship with El Paso County coroner so that we're able to receive and review the coroner's report in conjunction with who's been in our hospital and what could we have done better. I know that the northern region also has that really close connection with their coroner as well. So as a system, something we're trying very hard right now is to get a manager's guide to suicide post-vention in the workplace put into all of our system as a policy. And so that's something that we have requested go higher up within UC Health so that we can adopt it as a system. And then one last thing that the southern region has moved forward on, and I'm hoping that eventually UC Health as a system can also do, is we have adopted a peer support program. I'm sure many people on this call know how hard it has been to be in mental health, especially through the COVID pandemic. And we felt like we had a lot of staff members at risk for having some mental health needs that weren't being met. And so the southern region has moved forward on peer support. UC Health has trained physicians, nurses, behavioral health specialists, pretty much anybody you can pick within the UC Health staff members are being trained. And the peer support coaches were not professional counselors. We listen and provide support to other staff members. It is confidential. What is said to a peer support coach stays with that coach, of course, unless we feel like the person is in imminent danger. But the information that is shared is not sent back to managers or supervisors or HR. And we do feel like the peer support program is going really well. We would absolutely love to expand it, but for now, we're taking our tiny steps as they come and embracing them. And so that kind of in a nutshell is UC Health as a system. And for myself as the southern region, those are the steps on the journey that we've been through. And I'm happy to take any questions. I'm going to stop sharing my screen at this time so I can go back and kind of see who's asking questions. But I want to put out there again, it's not just me, it's everybody in our system. There are lots of individuals on this call right now that have put a lot of sweat and tears and hard work into UC Health moving forward as a zero suicide implementation team all together. So I'm going to welcome questions to them too. So any questions or comments you have, I'm happy to answer them at this time.
When you have a patient, this is Adena, and thanks for your presentation. I'm the manager of case management and psychiatric triage at Longmont United Hospital. When you have a patient who's a high risk from the Columbia Suicide Severity Risk Rating, how do you address your one-to-one watch situation? And what challenges have you found?
Absolutely. So there are a lot of challenges, especially hospital to hospital, right? Our 12 hospitals are very different in how they are. Memorial Central Care Unit 4 is a locked unit. And so they are on, the unit has video cameras. So we do a one-to-one assessment, even if they are in care unit 4, and it's deemed whether they do need to still have a sitter or not. And then if they are not, if there's no beds in care unit 4 and they're out in one of the other units, we do the one-to-one, but they do have a sitter with them at all times, which can be very hard with staffing, right? We're all short-staffed, especially through COVID. We were extremely short-staffed.
Right.
I will tell you Pikes Peak Regional Hospital, which is one of the ones down here in the southern region, is a very tiny hospital. And so when they do get a behavioral health patient up there, it's extremely hard to keep a sitter with them at all times. Usually they have one tech per shift. So that can be very hard to do. And we just do the best that we can with each hospital as we can. I do invite the other UC Health employees on here if they want to add to that or answer that, because it can be very different from hospital to hospital. And if they don't want to, that's fine too. I might have answered it since I gave an example of our tiniest one in the southern region to a very big hospital.
And along those lines, if I could add the following question, which is, at what interval do you perform your reassessments to reassess that risk rating?
We do that at a 24-hour interval.
Yeah, that's what I would assume. Okay, thank you for that.
Absolutely. And we understand that can be very hard. Being the zero suicide coordinator, if I don't have a lot planned that day, that's a point for me to take my computer and I can take my cards and write carrying contacts while being a sitter if need be. You know, we do what we have to, as I'm sure all of you guys do in your hospitals as well.
Thank you so much for all the good info, Robin. We also have had a couple questions in the chat. Elizabeth asked, to clarify your outpatient appointments, do the PHQ-9 add appointments? How often is that done?
So it's done differently throughout the system. I will talk to a few of them because I've gone in and done training with a few of the outpatient providers, and the nurses will do them when the patients are brought back to the room so that it's done in privacy. I do have a few of the physical therapy clinics that actually hand them a piece of paper and ask them to do the PHQ-2, and then if it's warranted and the PHQ-9 is needed, then they move forward on that. But they try really hard to provide privacy for that happening, which I'm going to tell you, I appreciate that. If I was being asked those questions and it was done in a room full of waiting people, I probably wouldn't be too honest about my answers.
I have a follow-up question to that. When it's a positive PHQ-9, is it the physician who's actually then following with them, even if, say, they're a pulmonologist, or is it somebody else who's called in?
It really depends on so I'm going to talk for the southern region only, not the northern or metro. For us down here, it depends on how comfortable they are. If they are in the hospital, if they are located in Memorial Hospital and I am available, I have been called to come up and follow through with them. If the doctor follows through and realizes it is an imminent situation, then they are escorted down to the emergency room and a full evaluation is done on them. So it's really a case by case, situation by situation basis. And that's why I feel like it's so important that all staff within an organization is trained on QPR, because if we're not comfortable with the questions or what's being said, how likely are we going to move forward? Even for me, it goes to say with QPR is compared a lot to CPR, right? I'm trained in CPR because I work in a hospital setting. But if I was not and I came across somebody that needed CPR, I don't know that I would move forward in helping them if I hadn't been trained. And I really feel like QPR is absolutely the same.
Thanks so much, Robin. We had another question in the chat. Matt wants to know how you moved forward with sharing data with the coroner's office.
So I will have to give all of that thank you to Billy Ratliff, my director, and Andrea Wood, my manager, because they had that set up before I came on. Our coroner is really amazing and believes very much in mental health. He's actually a member of the NAMI board down here in El Paso County. And so Billy and Andrea had reached out to him and talked to him about how important this data is to us and why we want the data and what positive moves we want to do moving forward with the data. And so they were able to build that relationship. I know that our northern region also has a very good relationship with their coroner. Julie, do you know how that relationship got started up in the northern region?
Yeah, so we, in the North region several years ago, we applied for a grant and got it to work on suicide, preventative measures just for Larimer County. So one of the gals on the work group had reached out to the coroner for Larimer County and had gotten that data. And I know that there were a few years that there were a gap for whatever reason. So I don't know if because the coroner changed or whatever. But after I went through the academy, because that employee had left the agency, had left UC Health, I emailed Rachel at Imagine Zero Suicide, who got me the contact information for the Larimer County coroner, and then who she thought would be the contact for the Weld County coroner. Long story short, they both sent me data. And so I have the spreadsheet of the 2021 names and all that identifying information. So I've been slowly looking them up in our medical record system to see, what kind of contact we had with them before their death. And so I'm just working on that right now. But the Weld County coroner told me that they years ago used to send it to our local Imagine Zero suicide folks, and then it just stopped for whatever reason. And they were happy to send it to me. So I didn't have any problems.
Thank you, Julie.
Thank you, all good info. Also, another way to share data and get that data back, there is the option, and again, I think some folks on this call here could speak to this process better than I could, about setting up a data sharing agreement between the Center for Health and Environmental Data and your organization. We have the Colorado Violent Death Reporting System here, which includes records of death by suicide, and the injury dashboard, which captures reports of intentional self-harm. And in setting up a data sharing agreement with CHED that allows data to flow in both directions. So CHED can identify your patients from the larger population, link them to those data sets, and send back that morbidity and mortality data. So alternative, or in addition to a relationship with the coroner's office, that's also been pursued by other people doing zero suicide work here. So just wanted to flag that opportunity. Robin, we also had one more question that came in the chat. If you have any guidance in training or policy for completing the SSRs on those under the influence.
So a lot of times for those under the influence, if they are not able to complete the Columbia screening, we will defer it. And then once they are sober, we will go back and do the Columbia screening at that point. Because we do feel like it's very important that we get accurate answers from them. And that's how. So with our Care Unit 4 in Colorado Springs, a lot of times, unfortunately, we have a lot of individuals that are just under the influence, but we need to maintain their safety as well until they are sober. So we defer and then come back and ask the questions as soon as they're able to answer them.
Awesome, thank you so much. Another question in the chat specific to QPR. Is it similar to motivational interviewing Is it specific to suicide, or can it also be used to talk to SUD patients, so substance use disorder?
So-
Yeah.
So I'll give you my take on QPR. I absolutely love QPR. It stands for Question, Persuade, Refer for those who don't know. And it's a great training to teach individuals the flags and warning signs to look for of an individual who is suicidal. Once you have those warning signs, how do you ask the question to those patients? And it gives you great indirect ways to do that so that you're comfortable asking those questions. And then it helps you to persuade that individual to get the help that they need. So as much as I love motivational interviewing, I wouldn't say it's like motivational interviewing at all. It's a gatekeeper training to how to help people help others who are feeling suicidal.
Awesome. Thank you so much, Robin, for this wealth of amazing information and your experience in UC Health. It's just been super valuable. I definitely think you should read through the chat. People have been saying you're a rock star, which you are, for all of this amazing work. And those on your implementation team, thank you so much. I know a couple of folks also asked if they could get your email in the chat too, just so they might reach out individually. As per usual, we will be sending out the slides and recording with all of this great conversation and resources. Thanks, Robin, for putting your email in the chat. And then they also are always posted on OSP's Zero Suicide webpage. If there aren't any other questions, I am happy to give folks some time back in their day. The next Zero Suicide Learning Collaborative will be next month, again, the fourth Thursday. So that's June 26th at 10 a.m. Please keep an eye out for a follow-up email where the Zero Suicide office hours will also be posted. But thank you so much again, Robin. Really appreciated your perspective today. And thanks so much for battling through your cold for us.
Thank you guys. So sorry about my voice, and I'm happy to help any way I can. And again, it's not just me, but my whole team at UC Health is amazing. So thank you to them as well. Bye, Conlin.